Good morning, everyone. Thank you for that kind introduction. First of all, it's my pleasure and I'm truly delighted to be part of this 12 Fora Cardiologia. Secondly, congratulations to the organizing committee and to the section of Cardiology for successfully hosting this virtual course. A warm greeting to all. My task for today is to explore the role of SGLT2 inhibitors beyond diabetes. It's actually a very interesting topic, not only surprises our colleagues from endocrinology, but also impressed the cardiology community. This lecture is not sponsored by any pharmaceutical industries and in no way influence the manner of presentation. Okay, in the last 12 to 18 months, results of several major cardiovascular and cardiorenal outcome trials in patients with heart failure with reduced ejection fraction came out with positive results. And still, we expect quite a number of promising results, not only from these big clinical trials, but also in secondary analysis from these trials itself in the next few years. Similarly, we expect this data on the use of SGLT2 inhibitors will be continue to expand and extend in the future. And so therefore, it is important to put this data into clinical context for all clinicians for their daily bedside rounds. So allow me to present two case scenarios which will allow us to better understand the role of this SGLT2 inhibition, not only in diabetic patient, but also in non-diabetic individual with history of heart failure with reduced ejection fraction. I will show you a few slides on what might be the role of SGLT2 inhibition in renal protection independent of blood sugar control or HbA1c level. And let's see how this data might affect or even influence our patients' management. Let's have the first hypothetical case, a very interesting one, not so complicated. A case of a 72-year-old lady, her name is Lydia, presenting with worsening symptoms of shortness of breath and fatigue with mild exercise. Her cardiovascular risk factors include hypertension and type 2 diabetes. Her cardiovascular history includes CABG 10 years ago for 3-vessel disease. She has ischemic cardiomyopathy with reduced ejection fraction of 34%. Her clinical conditions reflective of New York Heart Association class 2 to 3. Her pertinent lab results were LDL cholesterol fraction of 65 milligrams percent, A1C level of 7.0%, with a preserved EGFR of 71. Her medications include aspirin 80 milligrams once a day, sacubitril valsartan 100 milligrams 2 times a day, carvedilol 25 milligrams twice a day, eplerenone 25 milligrams once a day, metformin 850 milligrams twice a day, rosuvastatin 20 milligrams once a day, and furosemide 40 milligrams once a day. So what to do next? With this long list of medications, can we consider it a complete treatment armamentarium? Maybe not. Shall we start her on this new SGLT2 inhibitor? If so, what might be the arguments behind adding SGLT2 inhibitor or perhaps its limitation? Going back to our patient, she's already on antiplatelet and statin for her coronary artery disease. She's already on ARNI, a beta blocker, a mineralocorticoid receptor antagonist, and diuretic for her heart failure. And basically, she has everything that we used to give for treatment of heart failure until recently. But given the new data on SGLT2 inhibitor, and in here, I'd like to refer you to several large clinical cardiovascular outcome trials, like EMPA-REG outcome trial with empagliflozin versus placebo, canagliflozin versus placebo in CANVAS program, dapagliflozin versus placebo in DECLARE TIMI 58, and VERTIS CV trial comparing ERT to gliflozin versus placebo. This trial showed significant reduction in combined secondary endpoints on hospitalization for heart failure or cardiovascular death. In addition, some of the trials, depending on the population, showed reduce of 3-point major cardiovascular events, as seen in both EMPA-REG outcome and CANVAS program. And in one of the trials using empagliflozin versus placebo, showed reduction in cardiovascular mortality. Looking back to our patient has type 2 diabetes and she has everything that needs to treat her heart failure. But given the data that SGLT2 inhibitor has significantly reduced heart failure, hospitalization, cardiovascular death, most likely we could start her on SGLT2 inhibitor. One may argue that her A1C is well in range for her age and comorbidities, but this drug has been shown to be effective with respect to heart failure outcome independent of baseline HbA1c. Given the data I have shown you, dedicated heart failure trials have been conducted, and the first trial that came out was a DAPA-HF comparing dapagliflozin with placebo in a dedicated population with heart failure with reduced ejection fraction, and in this trial, enrolling patients with or without diabetes. And the recently published trial, the Emperor Reduce, and the patient population enrolled was actually complementary to that of the DAPA-HF. However, those enrolled in Emperor Reduce had greater baseline NT-proBNP and lower ejection fraction. Same observations were noted on these two cardiovascular outcome trials. The SGLT2 inhibitors, both dapagliflozin and empagliflozin, being compared separately with placebo, showed significant reduction in combined endpoints, and the benefit was incremental to the benefits of other heart failure treatments. And it was consistent across all subgroups, including those with and without type 2 diabetes. There was actually a 26% relative risk reduction in DAPA-HF for primary prevention of CV death, hospitalization for heart failure, or urgent heart failure visit versus placebo, while 25% relative risk reduction in Emperor Reduce in primary endpoint of cardiovascular death or hospitalization for heart failure versus placebo. Results from these two large, fully powered and randomized clinical trials offered a rationale for patients with heart failure, irrespective of the presence of diabetes, with remarkable improved cardiovascular outcomes. Surprisingly, Lydia has a normal kidney function. If I may recall, the eGFR is still more than 60, and she's not problematic. You might be asking, the presence of comorbidities like kidney failure, would it play a role in the choice of drug treatment? The answer, of course, is yes, it certainly does. So let me just step back a little. If patient has heart failure with advanced kidney failure, say 3 to 4, the prognosis before was seemingly worse. But for the treatment of these patients, data from randomized controlled trials with the SGLT2 inhibitors have demonstrated long-term protection against clinically relevant renal events with SGLT2 inhibition, including episodes of acute kidney injury. I will talk more about this as we proceed and as we study the second case. But current prescribing guidelines limit the use of these particular drugs in patients with advanced kidney disease. So let's see what the future holds for us as far as this group of treatment is concerned. The next question that you might be asking is, when is the best time to start this patient on SGLT2 inhibitor? Is it really appropriate to wait for our patient to stabilize after giving drugs for heart failure to overcome the current problems before we start SGLT2 inhibitor? You see, one of the current problems is recurrent hospitalization for heart failure. And if you look at this particular Kaplan-Meier curve, with all cautions that need to be applied here, the curve separates very early, suggesting that the effect of this drug kick in very early after initiation of this drug. So in order to prevent recurrent hospitalization and for patients to have a full benefit, patients should receive this drug very soon, once stabilized. There's a very good data showing that this drug indeed can be started in the hospital once the patient is in stable condition after decompensated heart failure. This data was published last year by Daman and his colleagues. It also suggests it's really not the safety issue. No problem with hypoglycemia, no problem with hemodynamic changes, but from the very early standpoint of getting the benefit early on. So it might be prudent to start this treatment early while patient is in the hospital after stabilizing the heart failure's condition. Okay, here we go. Going back to our patient. She's already on ARNI, beta blocker, MRA, diuretic, and now we're going to add SGLT-2 inhibitor to complete the spectrum of heart failure treatment. So our next concern is patient monitoring. Do we have some issues that need to be aware of? There are a number of factors that we should consider every time we start a certain medication for a heart failure patient, like low blood pressure, elevated heart rate, or even deranged kidney function. Do we need special measures to bring in the therapy on? First of all, the SGLT2 inhibitor can be used even if the blood pressure is low. The blood pressure lowering capacity is very low, and in some patients, BP reduction related with SGLT2 inhibitor, based on the large trial, was only about 1 to 2 millimeter mercury, but no more than that. It was actually a very small drop, which is not an issue compared with ACE inhibitor, ARB, or ARNI initiation. One issue that we should be aware of is the fact that once you start this patient with SGLT2 inhibitor, you get a drop in eGFR. This is explained by the mechanism because you get a decrease in intraglomerular pressure leading to slight reduction in eGFR. This is not something that is permanent, and once you stop the drug, you regain it again. And based on overall or available data, SGLT2 inhibitors provide a long-term protection against clinically relevant renal events, including episode of acute kidney injury. Now, how to start this drug? Several leading cardiac societies came up with their own recommendations based on the cardiovascular risks identified. And even other evidence-based guidelines from other societies like ADA and EASD are beginning to recognize the role of this particular group of drugs in the treatment of heart failure with reduced ejection fraction. As a cardiologist and to other colleagues listening, are we supposed to worry about the incidence of hypoglycemia? If you use drugs that do not cause hypoglycemia like SGLT2 inhibitor, DPP4 inhibitors, or even metformin, you don't run the risk of seeing hypoglycemic episodes. However, on patients with existing insulin or sulfonylureas, yes, adding SGLT2 might cause hypoglycemia. So better coordinate, therefore, with your endocrinologist or diabetologist. We might have to reduce the dose of the insulin or the sulfonylureas to prevent hypoglycemic episodes. As to adverse events, something that we should discuss is about genital hygiene. There are reports on an increase of genital mycotic infections with SGLT2 inhibitors. This is something that should deserve attention but should not defer the use of this drug. The previously reported fracture or amputation incidents in Canvas program was never duplicated, documented, or even reproduced with other trials and even with dedicated heart failure trials. We don't know if this is spurious finding, but something that never been seen in any of the trials. Okay, let's see the second case. It's a referral from another hospital. His name is Jose, a 68-year-old man with heart failure with reduced ejection fraction of 30%, complaining of shortness of breath when climbing stairs, unable to do many activities around the house that he normally does. No leg edema. His cardiovascular medical history includes diagnosed with heart failure after myocardial infarction 2 years ago, with LVEF of 30%, obese, dyslipidemic with stage 3 chronic kidney disease, and no diabetes. Here are the list of his medications: enalapril, 20 milligrams once a day, metoprolol succinate once a day, aspirin, 80 milligrams once a day, atorvastatin, 40 milligrams once a day, spironolactone, 25 milligrams once a day, high-dose furosemide of 80 milligrams twice a day, and a prostate drug. Pertinent labs showed elevated serum potassium at 5.5 and relatively high normal hemoglobin. Can we do something about Jose's heart failure treatment? Okay, Jose's relative low blood pressure might limit further up-titration of treatment following guideline-directed medical therapy. He was on spironolactone 25 milligrams daily with high dose of urosimides, plus currently on prostate drug. So most likely it includes alpha blocker, which might cause low blood pressure when added together. Shifting spironolactone to another MRA, say a eplerenone, should be considered, considering the BP efficacy or blood pressure reduction effect of the eplerenone is lesser. There was actually a meta-analysis showing that spironolactone has more blood pressure reduction effect than that of your eplerenone. Reducing the dose of furosemide is a logical decision to make. Not so sure either if high dose furosemide is needed, considering his kidney function is estimated to be about 30 to 60. Alpha blocker should be discontinued and should shift to another drug. And please take note that this guy has no edema and relatively high hemoglobin, so probably or typically over-treated with diuretic, causing hypovolemia, and that is predictive, especially if with ACE inhibitor, you get into persistent hypotension. This all limits the adjustment of treatment. How about enalapril? Enalapril is a classic drug and it has a short half-life of 3 to 7 hours. Honestly speaking, enalapril is no longer state-of-the-art treatment for heart failure. What makes this drug popular is because of the SOLVE trial published decades ago, proven to be of clinical benefit versus placebo. And that was the reason why it was used as a comparative treatment arm in paradigm study comparing with ARNI. And if you really prefer ACE inhibitor, you use another one with a longer half-life. But again, if his blood pressure got better and has improved, this guy is a good candidate for ARNI treatment, which has a better, rather overwhelming evidences to reduce the risk of hospitalization from heart failure and cardiovascular death in patients with heart failure with reduced ejection fraction who remain asymptomatic despite of optimal medical treatment with ACE inhibitor, beta blocker, and MRA. Another issue of concern here is Jose's renal dysfunction and high potassium. Elevated potassium could be explained as a result of combination drug therapy of ACE inhibitor and spironolactone on top of the range kidney function. So if we could increase patients' blood pressure, then we could give ARNI, that is actually a better step. There are several strategies that we could apply as stated above. ARNI, apart from can decrease the lessening of the eGFR, also reduce the risk of hyperkalemia in patients who take MRA together with RAS inhibitor as shown in paradigm study. So far, we have covered everything on this patient except for the SGLT-2 inhibitor. Our patient, Jose, is actually mirroring the inclusion criteria for DAPA heart failure and emperor reduced with LVEF of around 30%, considering his eGFR is only about 40 ml. He's an ideal case for one of these drugs. Before, the use of SGLT2 inhibitor was limited based on the impaired kidney status, but now, with the data at hand, data gave us more windows to start this particular drug. We should start this SGLT2 inhibitor based on prognostic and not on symptomatic values. So let me just summarize briefly the current list of his medications after careful analysis and observation. On top of his CAD regimen of aspirin and statin, ibabradine was started for better heart rate control. Beta blocker was switched to bisoprolol, which has a faster metabolites compared with that of metoprolol, and proven to be of good clinical benefit in combination with ibabradine. Diuretic dose was reduced, shifted to a eplerenone, and alpha blocker was withdrawn and shifted to a drug with no blood pressure reduction. Eventually, blood pressure increased to 110 to 115, and so ARNI was initiated instead of ACE inhibitor. And finally, added SGLT2 inhibitor. Again, if you're concerned about the blood pressure effect of SGLT2 inhibitor, there was a good data from the DAPA heart failure study. comparing dapagliflozin and placebo, showing that there's a very little drop of around 1 to 2 millimeter mercury blood pressure. So low blood pressure is really not an issue or contraindication for SGLT2 inhibitor. You might be asking what stage of heart failure or which level of the disease should we consider appropriate time to initiate such drug. Okay, let's try to go back to the outcome trials. The DAPA heart failure recruited patients according to ejection fraction and pro-BNP level. The threshold pro-BNP was quite low. Emperor reduced a more complicated combination threshold to include patients which have higher BNP adjusted to ejection fraction. Majority of the enrolled population falls into class 2 to 3 based on the New York Heart Association classification. Trials with SGLT2 inhibitor include a broad patient population, and the use of this SGLT2 inhibitor applies to majority of this stable heart failure condition. Another question that you might be thinking of, can you give this drug to patients who had an acute or recent onset heart failure? There is a good outcome trial that can answer this particular concern. The Soloist WHF trial, which is the study on the effect of sotagliflozin on cardiovascular patients with type 2 diabetes post-worsening heart failure. The goal of this study is to assess the safety and efficacy of sotagliflozin in reducing CV events among patients with type 2 diabetes and recent heart failure. Though this trial involves purely diabetic group, and though prematurely stopped because of the funding reasons as a result of pandemic, this is the first large randomized controlled trial to show the initiation of SGLT2 inhibitor in acute heart failure in stabilized patients prior to discharge or shortly thereafter is safe and effective. The benefits were consistent in those trials with heart failure with reduced ejection fraction, as mentioned earlier. Okay, looking at the abbreviated algorithm in the management of heart failure with reduced ejection fraction, both for 2016 in ESC and 2017 ACC and AHA, it's a sequential approach. You can start with ACE inhibitor or ARB with or without beta blocker, followed by MRA, and then may shift to ARNI on reassessment if possible. Ibabardine might be added if it fits the criteria, and may even introduce the device implantation treatment or approach if clinically warranted. So basically, everything is designed to narrow the gap of the risk of future event. But adding SGLT2 inhibitor might not follow the traditional sequential, but rather a parallel administration, meaning you can add this drug simultaneously with other treatments for heart failure. We have a number of positive major trials overwhelmingly support to put this drug into limelight, say under class 1 recommendation with A level of evidence. I would say shortly after decompensation, patients should be on SGLT2 inhibitor on top of this ARNI, beta blocker, and MRA. Of course, the problem is we cannot compare the efficacy of each of these drugs, and neither we cannot say which one is more important or better. I think the most thoughtful approach how to address it is to look and review patients' profile, look into individual risk factors and their combination, and assess, therefore, which of the following drug or drug combination patient should have. Say an overweight individual with elevated blood pressure, we can start ARNI with SGLT2 inhibitor, or say with high heart rate, we can start with beta blocker, adding again your SGLT2 inhibitor. For patients with hyperkalemia, we might have to step back a little with MRA and so on and so forth. In short, this will be a lot of individual decision by the treating physician, or it could be even part of the shared decision with the patient, which could also be a very novel and provocative approach. It is always and will always be a question as to when to start this drug, especially in our case, our second case, a non-diabetic male patient. Some of us might want to start this patient even on outpatient basis, but it's always the titration sometimes that give us the problem. The clinical inertia in the outpatient clinic setting is of course an issue, but I think this will not be an issue considering you give this particular medicine only once a day. Of course, it will be an ideal thing to do if we can start certain drug while admitted in the hospital for us to see and monitor what we want to achieve. Okay, last 2 points I want to impress on the group before I wrap up my discussion. First is the use of SGLT-2 in non-diabetic individual. What is the chance of hypoglycemia and DKA? Well, hypoglycemia is rare in non-diabetic individual, considering the glucose excretion is dependent on serum glucose concentration. The DAPA heart failure demonstrated no major hypoglycemia or DKA in patients without type 2 diabetes. Initiating this drug while admitted, the more we should be less concerned considering we can easily monitor this patient closely and adjust the treatment accordingly. I think the bottom line here is, as far as the safety issues are concerned, it is for us to see the patient, and once we see the patient, we can overcome some of these issues. The second point I want to raise is on the EGFR. Let me go back to the previous issue on the drop of EGFR. What would be the beneficial effect of this drug over time? The nephroprotective effect, in other words. Once again, based on the clinical trials earlier discussed, once you start SGLT2 inhibitor, there will be a small drop in EGFR. You might not necessarily see an increase in creatinine, but this is due to the fact that the tubular glomerular reflex is attenuated by SGLT2 inhibitor because there's a small vasoconstriction of the vas afferens and therefore translated into drop in filtration pressure initially. However, the reduction in the filtration pressure is the mechanism of the nephroprotective effect because you take out the pressure on the glomeruli and therefore less damage to the filter. And basically, that's the same effect of this RAS inhibitor who has a vasodilatation of the vas efferens. So goes together, efficiently drop the filtration pressure, and the long-term follow-up, you might be able to see a sparing effect on the rate of decline in renal function and improved in essence by the SGLT2 inhibitor. The reduction of EGFR is not only seen in diabetic, but also true for non-diabetic group with heart failure with reduced ejection fraction. And this is, as you can see, taken from the DAPA heart failure trial. The renal protection of this SGLT2 inhibitor extend beyond diabetes. It is really with the remarkable reduction, the decline of your EGFR, substantial reduction in the risk of developing end-stage renal disease or renal death, and approximately 48% relative risk reduction compared with placebo in Emperor-reduced trial. And now we have add-on effect, and I guess everybody's excited, and perhaps the break-even point is 1 to 2 years to see improvement of the glomerular filtration rate. But of course, it all depends on the presence of other comorbidities like hypertension and diabetes. The mechanism of SGLT2 inhibitors that provide cardiovascular benefits are complex and multifactorial. It has a unique glucose-lowering agent, and at the same time has multifaceted effects on hemodynamics and metabolic parameters beyond glycemic control. However, the precise mechanisms by which this SGLT2 inhibitor affects benefits on cardiovascular systems are yet to be elucidated. We are now facing several unanswered concerns lurking behind the successful trials. They don't act as diuretics, they don't even act as hypoglycemic agents, but these drugs proven to protect the heart and the kidney. Now, to summarize what we have discussed so far, I have shown you data on the use of this drug beyond diabetes using the 2 case scenarios. Your SGLT2 inhibitors are safe and effective on patients with heart failure with reduced ejection fraction beyond diabetes. These drugs appear effective in broad range of heart failure with reduced ejection fraction in terms of reducing heart failure related endpoints. It has also significant favorable cardioprotective and renoprotective effects. And lastly, this group of drugs are actually well tolerated in a high risk population. With that, thank you very much for your kind attention.
Thank you so much, Dr. Raul Lapitan, for that very extensive review on the SGLT2 trials, both for heart failure and renoprotective benefits. Indeed, that case-based approach, Doctor, that you did was very unique and very helpful and informative. I
Thank you,
don't
Edwin.
actually see any questions on the chat box, but I would like to throw one. You mentioned on your last few slides about the possible mechanisms behind the benefits of these drugs. If you look back at the DAPA-HF trial, there was a mention that the drug actually did not lower pro-BNP levels, and neither was it significant for its glycemic control. But what then was the possible postulated mechanism for its cardiovascular benefit over and beyond natriuresis?
Yeah, thank you, Edwin. Can you hear me?
Yes, doctor.
Thank you. Excellent questions. I myself actually looking also for some potential mechanism or reasons behind this. But what I got from several studies that number one, of course, is even though none of these trials could discern any relation between changes in glycemic control and the effects on heart failure, some researchers actually believe that mitigation of the glycemic-related cardiotoxicity could contribute importantly to the observed reduced risk. But of course, with the presence of this dedicated heart failure among non-diabetic, that's actually undermined that potential postulate. Other investigators suggested that it might be natriuretic action of the SGLT-2 inhibitors could cause a reduction in plasma volume or interstitial fluid, which might reduce cardiac volumes and favorably influence ventricular remodeling. I just have to see a study or data that might say a subgroup analysis looking into the hemodynamics or say ejection fraction in particular. Still others suggested that SGLT2 inhibitors might favorably influence energy balance in the failing heart by increasing the circulating ketone bodies and by promoting a shift in myocardial fuel utilization from glucose to ketones and free fatty acids. And additionally, the SGLT2 inhibitors were postulated to enhance the synthesis of erythropoietin, with the expectation that an increase in red cell mass might increase oxygen delivery to the myocardium, which could be important in those with underlying ischemic heart disease. Now, if I may continue, Edwin, how about, because we also see based on the DAPA-CKD trial, apparently we were able to see potential improvement or benefit in the long term. It's been pretty well demonstrated that the protective effect we're seeing here in the trials like DAPA-CKD, and if you're familiar with the credence, using canagliflozin versus placebo. The DAPA is dapagliflozin, and the other one is the SOLVE scored trial by sotagliflozin, which apparently had a non-inferior effect as far as the renal endpoints. But for the DAPA-CKD and for the credence, there might be other effects other than the blood glucose or on blood pressure. The other effects they've been well publicized is in the effect of the transglomerular pressure. Reducing glomerular filtration or hyperfiltration can help protect against CKD progression. Certainly, the initial decrease in the GFR seen with patients in these drugs could point to that as part of the mechanism. There was one discussion to those who are actually very well versed with the Medscape discussion. There was one discussion In fact, they considered SGLT2 inhibitor as beta blocker for kidneys. No, they said that in the sense that this group of drugs trying to reduce the workload by blocking the glucose reabsorption, but it may also point to benefits in terms of mitochondrial function, suppressing oxidative stress and restoring autophagy. So that's basically cellular in nature.
Okay. Thank you so much, Doctor. I think Melissa has a question, but before I turn it over to her, I would just like you to entertain this one question in the Q&A box. Are these drugs useful in CHF or with preserved ejection fraction?
That's a good question, Dr. Versosa. There are actually two ongoing trials for Preserve. One is the Emperor Preserve, and the other one is the Deliver by dapagliflozin. And soon, I guess this year, it will be out. In relation to that question, what might be the group of patients that this group of drugs should not or be cautious in giving this? No, aside from Preserve, until we have the data. Second is those patients with end stage kidney disease, because the Emperor Reduce actually only considered more than 20 EGFR, while the DAPA considered more than 30. So patients who has lower EGFR of less than 20, we might be very cautious about it. And lastly, those patients with type 1 diabetes mellitus, for the reason that this patient might go into a DKA problem.
Melissa?
Okay, actually, that was already answered some of my questions. But what is the mechanism of DKA in, for example, empagliflozin? And have we seen it also in dapagliflozin?
Actually, the one I raised earlier, it's the natriuretic effect. That's why you have to be cautious giving this kind of drug in a type 1. They might go into severe dehydration.
So even with dapagliflozin, doctor, there's also a signal for that?
Yes.
Okay. Thank you very much.
And sorry, Melissa.
Yes, I think Dr. De La Rosa question.
As a question here, how safe it is to use SGLT2s in patients who are 80 years old and above with stage 3 CKD, but no diabetes, but with HFrEF. So 80-year-olds, CKDs, no DM, HFrEF.
And the kidney function, again, sorry.
Stage 3, doctor.
Stage
CKD.
3. Again, we have, I can answer that based on the data available. Unfortunately, those group of patients actually are less well studied, but I don't see any reason why we cannot use this even on very elderly individual. Of course, you have to monitor what we should monitor.
Okay. I do not see any further questions on the Q&A box, nor have I any other questions for you, Dr. Raul. It was a extensive review of all of these trials for SGLT2. So with that, thank you, Dr. Lapitan.